welcome. The theme of India's G20 presidency was foreseen by our founder, Professor Dr. S.P. Muzumdar Sir, who constituted it as a basic principle and motto of Symbiosis International University, eliciting pride and rousing adulation. Symbiosis International University has grown to become one of the most renowned universities in India, with a reputation for excellence in education and research, was awarded with A++ grade by National Assessment and Accreditation Council.
Good afternoon, guests, delegates, and everyone present here today. I, Dr. Niharika Datta,
And I, Catherine Thomas.
welcome each one of you to SYMHEALTH 2023, a national conference on stakeholder engagement for integrated healthcare futuristic approach. Celebrating the Silver Jubilee, this annual mega event with a legacy of 25 years attracts 1,200 delegates from all over India and abroad. We request Dr. Rajiv Yarevdekar, Provost, Faculty of Medical and Health Sciences, Symbiosis International University, to accompany our guest of honor, Mr. Siddhartha Bhattacharya, Secretary General, NATHEALTH, onto the dais.
With great honor, I now introduce Dr. Rajiv Yarevdekar, Provost, Faculty of Medical and Health Sciences, Symbiosis International University. Being a fitness fanatic himself, Sir is a strong believer in incorporating health into work, ethos, values, and practices of the institution, whether it is in the area of nutrition, exercise, work, play, or academics. As a result, the promotion of health is a fundamental tenet of all aspects of the university. Under Sir's direction, Symbiosis carries out a number of community-based healthcare initiatives with an emphasis on students' preventive, curative, and promotional health. We now request you, Sir, to kindly deliver the welcome address.
Good afternoon, everyone. The guest of honor for this inaugural function, Mr. Siddhartha Bhattacharya, the Secretary General for NATHEALTH, a national level organization of which I am a member. Dr. Anupam Sibal here, long friend, a friend of long, not a friend of old. Dr. Tutakne sir, Dr. Jamkar, Dr. Shingare, Chair Professors and Professor Emeritus at the Faculty of Medical and Health Sciences, Dr. Bhama Venkatramani, the Dean Acads and Administration at Symbiosis International University, Dr. Hardik, the Director for the Quality Initiatives at the Symbiosis International University, faculty members, directors, Dr. Parag, Dr. Alka, Dr. Samhita, and so many. Dr. Ruchika is here. She's the Director of the Symbiosis Center for Research and Innovation. Dr. Parimala is here, the Director for the Center of Online and Digital Learning. And most importantly, my students who have completed or on the verge of getting their final completion endorsement of the distance education programs or the online and digital programs which you have pursued for the last 1 year. Well, I welcome you to this 25th edition, the Silver Jubilee edition of the SYMHEALTH. We started it way back in 1998, and it's nostalgia down memory lane, when at that point of time, the first inaugural batch had very illustrious students, one of which happens to be sitting in this audience and was then the commandant of the FMC and then later on became the first vice chancellor of the university, Dr. General Tutakne sir, who happens to be an alumnus. And the other day, they were discussing about whom to confer the Star Alumnus Award. We generally do confer Star Alumnus Award for alumni who have done good for themselves and have done the university proud. And I don't think so you could have got anyone better than Dr. Tutakne to be a worthy recipient of this award. But then the organizing committee came up with their own bureaucratic and technical constraints saying that he is not eligible because he's still associated with the university and there would be a conflict of interest of office. So as things stand today, this year, we will not be having the Star Alumnus Award because two of our other illustrious star alumni, one, Dr. Pramod Sawant, he is the Chief Minister of Goa, Medico, and he had done this course way back with you, sir, in a couple of years junior to you, 2002. And the second one is Dr. Sanjay Og, the former Vice Chancellor of of the D.Y. Patil University, Nerul. Unfortunately, he's down with COVID, and we don't confer the awards in absentia. So this year it stands suspended, but I'll, in the meantime, try to work around a hurdle whereby we can have you bypass and installed as the star alumnus. Be that as it may be, the theme of the SYMHEALTH is this time stakeholder engagement for an integrated approach to healthcare. And when we talk about an integrated approach to healthcare and we talk about stakeholders, who all are the stakeholders? The stakeholders is every single member of society beyond the healthcare sphere and beyond the healthcare domain. It's not only the doctors, it's not only the nurses, it's not only the administrators, it's not only the dietitian, it's not only the researchers, it's not only the policymakers or the regulators, it is everyone who has a stake in the healthcare pie and who can contribute to effective healthcare delivery. You talk about big tertiary care hospitals coming up, you talk of quaternary hospitals coming up, and Anupam represents one of the largest conglomerates of the largest hospital chains in India and overseas, the Apollo Group. He'll be talking about it subsequently. And within the healthcare domain, there are the insurance guys, there are the guy who talk about health systems, and we had a couple of discussions on that. And very basic, essential components of effective healthcare delivery on healthcare communication. Kari, are you here, or Kari would have left? Dr. Kariappa spoke on healthcare communication, and that's an interdisciplinary topic which today is probably the bane and the stigma on we healthcare providers, because we doctors, we nurses, we healthcare providers are not formally trained to communicate and communicate effectively. And that probably, my friends, sows the first seed of litigation in the patient's mind. It's not only necessarily restricted to breaking bad news or conveying an unfavorable or an untoward outcome. The simple concept of providing options of treatment, the choice of going to a particular diagnostic center to undertake the investigations ordered, how effectively do we have the time, energies, and most importantly, the inclination to talk to the patients or their relatives. And healthcare communication is one of the basic things which we see becomes the Waterloo of the healthcare delivery system. The lacunae in the healthcare systems, strengthening of the healthcare systems, amply brought to the forefront by the COVID pandemic. And one such dimension which emerged in the COVID pandemic is the derailment of mental health. And we have with us here Dr. Girija Male, who heads the Symbiosis Center for Emotional Well-Being, as well as Dr. Suresh Badamat, who comes from a center, an institute of iconic eminence, the Niemans, who will be talking to you about this derailment in the mental health and what can be done, and the mental health status of even healthcare providers, which is, so as to say, gone for a toss. Clinical research on clinical data management, pharmacovigilance, the regulatory approval, some of those components were discussed by Sani Davis and other faculty members who were invited. The objective is to sensitize you all who would be governing and implementing healthcare delivery in the years to come, get a ringside view beyond the narrow tubular confines of the programs you have enrolled for. Because it is basically management of healthcare delivery systems, healthcare systems which encompass a gamut of operations, which is so complex and spreading beyond individual domains. And to the core of all this is the development of what we call the man behind the machine being most important. And Anupam and all the speakers would be talking about the importance of finding the leader within you, developing a team, and tomorrow also you've got a couple of speakers talking on the same. Ultimately, every organization is hungry and thirsty and craving for manpower and quality manpower. and healthcare is no exception. And today, as we sit governing the Symbiosis University Hospital and Research Center or the Symbiosis Medical College for Women, we understand where the shoe pinches the most. And at the university, Dr. Bhama and her team, along with Dr. Gupte and Dr. Vidya, whom you would be interacting with subsequently tomorrow, understand what it takes and to nurture a university to get the status of a A++ by NAC. Many developments taking place on the national scene. Today itself we had the mention, yesterday in fact, about the National Medical Equipment Policy. I'm sure Siddharth is going to be touching on that. Many interesting developments happening all across in the healthcare sector through the NATHEALTH, through FICCI, through ASSOCHAM, many other organizations, many other professional bodies. But together, we all have to ensure that we, as the guardians of healthcare, live up to quality not at the cost of and compromise, at the risk of undercharging, or cost not at the risk of cutting down on the quality. So that's a delicate balance. We also need to be vigilant about the advent and the influx of technology. And technology in healthcare is coming in a big way. Probably the healthcare providers of our generation, and I don't say much of a gap between you and us in that sense, just being on the wrong side of 50, is the advent of digital technologies in healthcare. And we need to understand that digital healthcare is here to stay, and we need to undertake, we need to change our mindset to adopt technology with all its with a friendly approach. So I welcome you to this 25th edition of the national seminar called SYMHEALTH 2023. And I'm sure the deliberations, the discussions, and the experienced personnel, which Dr. Parimala and her entire team, Dr. Sanika, Dr. Sarika, Dr. Neha, where are you? I think so they are running helter-skelter, arranging things, and they have done a wonderful job, constantly keeping in touch with you, understanding your requirements, clearing doubts, ensuring that your assignments are assessed, and keeping the results ready. So congratulations to the team, and congratulations to you all who have committed time, energies for professional upgradation. Thank you so much.
Thank you, sir. I now request you to kindly felicitate our eminent guest of honor, Mr. Siddhartha Bhattacharya, Secretary General, NATHEALTH. Thank you, sir. Now, let us proceed to the keynote address as part of the inauguration of SYMHEALTH 23.
With immense gratitude, I take this opportunity to introduce Mr. Siddhartha Bhattacharya, Secretary General, NATHEALTH. Being an executive alumnus and scholar from Kellogg Graduate School of Management, USA, Sir has over 20 years of leadership experience in health, technology, and technology-enabled services in sectors across India and the USA. He has demonstrated his leadership skills in India's public and private health sectors, where he is responsible for driving scalable innovations, operational delivery, and technological leadership. Most recently, he worked as country director with Access Health International, a renowned global health advisory group think tank, whose goal is to increase access to high-quality, affordable healthcare for all. Being the foundation of the Emergency Medicine Management and Research Institute, he oversaw the design and development that led to better emergency health service delivery throughout India. We welcome you, sir, to deliver the keynote address on the future of healthcare with personalized touch.
Thank you so much. A very good afternoon. Thank you, Dr. Rajiv, eminent dignitaries, academicians, good friends, Dr. Anupam, good to see you again, faculty, students, everyone, and thank you for inviting me. I think, a couple of months back, Dr. Rajiv and I were in the NATHEALTH office, and we were talking about what's the one thing that you see in 10 years or 15 years from now happening in healthcare. And both of us agreed that it was going to be convergence. And healthcare is fast becoming more networked, more patient-centered, and more integrated. And that is, for someone like me who has been in healthcare for almost 2 decades, it's a very heartening thing to see that the pace of that happening in the last few years, particularly during COVID, is picking up speed. And it's fast, it's a direction. Still, there's a lot of distance to go. And I'm hoping that today in this presentation we can touch upon some of the key connecting threads that will help us in that journey. I don't know how the slides move, but next slides I'll kind of give you a cue. I'll start with the first slide, what I have here. It's okay. And I think the big piece for a transformation into a integrated health, which I'll define shortly, is really coming up with a strong NCD and a preventive health foundation for the country. And this is a 2035, I've noted this as an ambition, an integrated patient-centered policy specifically directed at preventive and NCD management. It broadly has pieces of it in works, but in terms of bringing it together, the 4 key pillars, which are really a national well-designed screening program, which prioritizes NCDs and the impact it has on overall health indicators based on evidences. The ability for us to redesign our benefit packages to recognize that preventive and curative have to coexist and balance each other. In terms of redesigning mandatorily the screening protocols for health wellness centers, as well as really tech-enabled large-scale community screening programs. One particular vertical for this roadmap towards a very robust preventive health is really screening. Second area is really in terms of the infra and the business model requirements. And here, really a public-private partnership is eminently possible in terms of, really the role that, we can play in aggregating small private clinics in urban settings, particularly differentiated payment norms, not only fee-for-service, but DRGs, P4P, capitation sort of payments, public-private partnerships for essential, efficiencies and innovation, as well as finding a way to engage with the not-for-profit sector and the community-based organizations. The role of digital stack, and we'll go a lot more into this, really in terms of the registries, the ability, the interoperability in standards, and the information exchange. For example, if I'm sitting in an urban health center, for us to be able to see a patient who's coming to you with, let's say, chronic, stomach pain, being able to link that case to the to the sanitation, water, environmental determinants of health, and being able to see is the water level appropriate in the community, and being able to share that information seamlessly across in a promotive and a primary care setting is of paramount importance. And finally, the health-seeking behavior changes. I always, in India, we have certain areas where we say, we pay 1,000 rupees for a mobile screen guard, but we don't pay 500 rupees for a helmet, right? So we just have to find ways to really change that behavior. We definitely get our cards serviced methodically every 6 months, but if you really look at even some of the best corporates in the country, the adherence to preventive screening annually, and you will find that number less than 30% for sure, right? But in terms of coming up with, innovative insurance products, health awareness campaigns, really tax breaks and tax-funded incentives to kind of get into the preventive, promotive side of healthcare. And this has to be ably supported by organization talent development, a real strong political will, and of course an adequate redeployment and reallocation and renewed commitments towards preventive and primary health in the country. So I think a lot of the big changes ahead, if I were to just size this up, this is not a small amount of cost that India is going to face. In the next 10 years, depending upon which data point I refer to, if India is going to be a $5 trillion economy, the cumulative cost of NCD burden is going to be more than that, right? In terms of, and this is a systemic risk, a multiplier effect to all other sectors in the India's economy. So it's a very critical area to look at. So with that in mind, an integrated healthcare, what is the need for integration in healthcare? What is the need for convergence? And broadly, if I were to look at WHO definition of healthcare, there are probably 3 large blocks in healthcare: financing, the provisioning or delivery of healthcare, and the governance side of healthcare, right? With critical enablers somewhere kind of connecting these 3 dots. Financing in India is fragmented. All of us know that nearly 2 out of 3 rupees that we spend is out of pocket. So the pooling is really at a household level, which leaves vulnerable households exposed to catastrophic shocks. If you look at the provisioning side of healthcare, more than 90% of the healthcare is really delivered by very small nursing homes, often less than 15 to 20 beds. And the governance side of healthcare, as we all know, healthcare is spread across at least 7 to 8 different ministries. And with the whole center-state federated architecture, that complexity is pretty large, and it can become, there are more permutations and combinations. So integrated health, a better approach for an evolving approach for future, is really a collaborative approach for all the stakeholders for a better patient care that combines multiple therapies. It's not polluting the therapies or really bringing therapies together, but some degree of collaboration between all different therapies that exist, with the strategies and professionals aligned with an end goal to provide holistic treatment and provide a wide array of chronic condition management. At the heart of it is patient-centered outcomes, which is measured, reported, tracked. Multiple health professionals work together collaboratively. Data flows smoothly in an interoperable fashion, and there is a large defragmentation, which saves cost and productivity. In the coming slides, if you put integrated healthcare at the heart of the health system, then around it the continuum of care from preventive, promotive, curative, rehabilitative, and palliative, these aspects which follow the life cycle of a patient or an individual, not when they're sick, but when they are potentially not sick. This approach prevents people and many people from falling sick, thereby allowing for redeployment of resources towards keeping people healthy. So some of the key attributes, not all of them, one is focus on preventive promotive health, which I've already talked about. Integration of services leads to lower fragmentation on demand. And often this is misunderstood at the load on curative services. Yes, the curative services will deliver better quality if they are not treating next to and on the same beds, people with just ordinary fever, along with, let's say, a transplant patient. So the mix of really hospitals that can be tiered for complex cases with the kind of specialization quality it's required to get end results. There will be far better improvement focus on the mixes of those hospitals. And the continuum of care approach retains the beneficiaries broadly within one ecosystem. So you are able to track them from wellness to sickness and sickness to back to wellness, including those sort of intermediate behaviors that keep people healthy. Also, it forms a closed loop from primary care, promotive care, to all the way to palliative care. Community health care, often the entry point of someone into the health system today could be a tertiary care hospital, but usually that is an inverted pyramid. The real pyramid is where patients come in through community-based primary care, Referral transport brings patient from one facility to the other based on structured protocols. Referral hospitals, secondary level hospitals manage or take the load away from a lot of tertiary hospitals on cases that can be managed in secondary settings, and tertiary hospitals provide super specialty care. And this also creates career path, skilling, and an ability for triaging and an ability to load balance, particularly for many of you who knew the cases around COVID, which just happened in the last 2-3 years. Not all the cases were equally serious or equally severe. Having some sort of an upfront triaging system to be able to grade what is more serious, what has to be dealt at a secondary level, what can be dealt at a primary level, what needs to be dealt at a super specialty level, would allow that care to be available to many more and not only a few, right? Don't go into the charts here a little bit, but I think the key message in this integrated approach, why should this be a better way of looking at it? Reduced cost burden, surely less morbidity, more productivity, and ultimately diversification of health services demand, which basically means all sorts of patients with all sorts of problems are not kind of coming and crowding in the same place, and you are able to segment, and you are able to, as opposed to creating gigantic facilities in one place in a land scarce country like India, you are able to provide better distributed healthcare, which information technologies allow you to do. Ultimately leading to lesser load on curative services, better quality of services, more demand and opportunity for non-curative service providers as well. So this is a slide I've already talked about. I think one important perspective here is 1.4 billion people treating or managing 1.4 billion people would mean that our design of healthcare systems has to be extremely flexible, scalable, and if we really look at the current challenges that we have in the supply side, across all sort of supply side, money is scarce, people are scarce, training is scarce, then there are vast inequities, between different geographies in terms of demand and supply. So we need a model that ultimately is a flexible model and a model that is an interconnected model which can load balance with each other. I think that's what I was kind of trying to get to. So what has been, if that is the base scenario, then what have been some of the major public sector or government initiatives which forms the bedrock of this convergence? About 3 or 4 years back, government launched a massive plan for upgrading the primary care centers into health and wellness centers. And this is based upon continuum of care approach, which means health sub-centers, primary care centers should be upgraded into health and wellness center. A lot of the mobile community teams would would be managed by the health and wellness centers. And there's a whole range of services or benefits that the health and wellness centers which are going to be able to do, which are far more upgraded from promotive rehabilitation to palliative care services. And that was, at least the intent was very clear, that it is about strengthening the front line. The second big change that has happened is the whole Ayushman Bharat digital health mission that has come through. And it basically calls for integration of all healthcare stakeholders through standard digital pathways. It is talking about common registries, which are around patients, around different diseases, different gamuts of, healthcare, all the registries being standards, which means there is one truth and not multiple standards of truth. Unique patient IDs like ABHA, Unified Health Interface based on the UPI architecture, so that you don't have to have one standard sort of digital health hardware. You could use your existing IT systems, but the standards make things through simple APIs interoperable. So a very large effort is underway as we speak to make a kind of a standalone facility-based healthcare silo and get in and take it to a connected sort of a world, which is a more networked play. And third is, and some of these, what government is trying to do is still a work in progress. It is really integrative health policy. India is not, there's not one health system in India. There are multiple health disciplines. There is a system of traditional medicines, modern medicine in India. And government is looking at ways to see at what part, this can be bridged where the best out of both can be harnessed without diluting any of the core essence or the ethos of each of these systems. And ultimately that means more capacity, more flexibility, more reach of the healthcare system, and this is a policy that is still in the making. I'm happy, this is a slide, I didn't know Dr. Anupam would be here, but this is a slide from Apollo's perspective, and even for private sector, there are really players who are fast emerging and morphing from being, they are fast generating or developing capabilities to serve the end-to-end spectrum of healthcare at a community level. So almost like a telecom operator, you can sign up for a service and for anything for your entire life cycle, what you need from healthcare perspective. You may have a network, and it has a digital, often a digital first front through which somebody enters. You are able to quickly create an electronic health record, a patient health record. You are able to quickly understand the risk profiles, create a profile of yours compared to a million other profiles, a very powerful way to detect what are your risk pathways. And then you have integrated services that talk to each other irrespective of where you go. As you transact more and more with this health system, it gets more and more intelligent about what you as a patient need. And you are constantly being kept updated with latest R&D. There's a culture of innovation, clinical expertise, and you have a multifaceted team looking at you as an individual through your life cycle as your needs evolve. And this is a way where large networks, you are moving away from a single transaction with the customer to saying, I'm going to be a partner for you. As your needs evolve, as your family's needs evolve, I know you can trust on me being an end-to-end. Even if you change your jobs, go to another alternate geographies, we can keep this relationship alive, and the data that we gain about you will be used to keep you healthy and not only to treat you when you are sick. So with that in mind, the opportunities for integrated care in India, there are many reasons why this is, and I think some of them I have touched, the scale of our challenges tied to our very large population. Interestingly, healthcare purchasing power in India, 73 million households are moving into the middle class category, which means 8% of Indians will earn more than 12,000 per annum by 2026. Senior citizens in India, the cost, there are going to be 300 million senior citizens in India by 2050. And along with China, I think it's almost between China and India, you're going to have more than half of the senior citizens around the world, which basically means you can't have a transactional or a one-off healthcare system because they're going to be heavy consumers of healthcare and you need integrated ability for you to, for them to transact. Nearly 5.8 million Indians die from NCDs, 60% of all deaths. 1 in 4 Indians have a risk of dying from NCD burden before they reach 70, with a huge cost to the economy. Home care, something you would have seen during the COVID, is fast emerging as an effective care, both post-hospital discharge as well in many cases before you even end up in hospitals. The growth in the healthcare industry, the ABDM, which you've already spoken about, universal health coverage, the 2017, the National Health Policy, at least laying a roadmap, at least laying the intention clear that India would like to go there. And demand and supply, huge inequities in terms of physical infrastructure and physicians and the number of nurses per 1,000 population, if you look at by WHO standards. So there are opportunities to optimize, to gain better productivity, get better customer value out of these. The solutions lie ultimately in the tech-enabled, integrated care stacks, the digital health stack as we see, harnessing the positives out of private sector. And this is an area, I know if you look at the NSSO studies, you will see that roughly 70% of the care surveyed are delivered by private sector. Although private sector is not monolithic, different parts of private sector. 30% is really from public sector. But I think the world is moving towards not the end place where the care is getting delivered. In terms of the value chain associated with the delivery of a care, even in public sector where care is delivered, a significant part of the value chain component is driven by private sector. Whether it's a reagent which is going into the diagnostic test, it's the machine in which an MRI test gets done, whether it is a pharmaceutical that's being used. So in terms of serving the patient, I don't think that public-private, there has to be a value chain level integration, and ultimately it has to be clearly seen in terms of a benefit of patient, how these kind of sectors we are able to harness each other's potentials. A huge number of startups, over 8,000 startups in India's healthcare space, and nearly valued at $2 billion. But however, I must say, while you have 8,000 startups in India right now, within NATHEALTH, we keep a fair track. Every year we have a interaction between some of the real market-ready, industry-ready startups, and have this carnival or interaction with the top industry leaders. The real robust, the ones who have had more than, let's say, 3, 4, 5 crore revenues or more than $1 million revenue, are still, a small fraction out of it. So there's a need for us to not only promote more supply, but also work with them so that they're able to scale and create the right ecosystem. Navigating quality healthcare, meeting unmet needs, increasing NCD burdens. I will just add 1 or 2 data points here. Quality of healthcare is an extremely important area. And India has some of the best quality at a fraction of the costs of what your countries outside will be able to produce. Vice versa, what makes it is the predictability of that quality, for us to have a minimum assured service of quality. The initiatives like NABH, NABL are very timely and noble. We just have to find a way to bring up a very vast section of the providers or the manufacturers who are just under that quality standard. Just like, when you go to a bank which looks for your credit worthiness, in a healthcare, there's no chance to make a mistake. It's the difference between life and death. First rule of healthcare is do no harm. So it's important to tie every aspect, every touch point of a healthcare institution and make sure that the evolution, that the ones who are quality conscious actually scale, and the ones who are not are encouraged to follow the right doctrine to scale. These are some of the points which are going to be key drivers. So I think I'm just going to go in the last few slides. I think the important transition points or the inflection points. This chart talks about, on one axis, quality of care and efficiency of operations. The other is the scale of operations. Our belief is from today's model, and it's already moved with ABDM into a more networked architecture. So for example, if you went to a hospital in Calcutta and you moved anywhere elsewhere, your records, everything else are seamlessly available, it's in the cloud. But I think from there, the networked healthcare architecture, you're going to move towards integrated healthcare delivery, which would be delivering healthcare. And integrated healthcare management is about keeping you, preventing you from falling sick. An extreme example of an integrated health management system would be capitation, where you take a baseline of a population and look at their morbidity factors, look at their baseline health indicators, and you pay a provider if people in that population become more sick than the baseline, and then the provider is going to find it difficult because it's going to cost them more money to send them to hospital. So the entry point of financing into the healthcare in a capitation mode is basically for ensuring that you are able to manage and improve the health outcomes. So, and this basically means balancing your preventive primary along with the curative side. So from today to tomorrow, the key inflection points are going to be treatment of patients, which is episodic care towards health of citizens. And many of the organizations, the chart for Apollo shows you that's all that transition is already in progress. Facility-centered to patient-centered, episodic care to lifetime care and preventive. Hospital-based to decentralized and community-based. Reliant on the doctor, patient actively, it's not the right wording. I think the wording would be patient actively not only managing their whole thing, but taking responsible for their own well-being. So that example of 20% or 25% in a tier 1 corporate going and doing preventive screening is not a good example. I mean, I went to China, and that number is over 90%. And it's because in a corporate insurance program, if you don't do your preventive checkup once a year, the insurance company is bound to report it back to the corporate, and it's seen as you're not very sincere about your health and you're not very responsible, right? So there are ways, I mean, that may not work in India, but I think we need to find ways to take charge of our own well-being. And then finance for consumption to incentivize for outcomes, not only activities. The fact that India's healthcare consumer is ready to accept the digital shift, even before ABDM, STAC, and all other major announcements with little or no concerted efforts, minimal support from healthcare payers, and in absence of even ABHA and EHRs, online pharmacies, about 400 million people use digital health application today in some way or the other, very large. Online pharmacies, online doctor consultation, fitness, wellness, home delivery, home healthcare, e-diagnostics. These are some of the very, very large areas. But this is just scratching the surface. And really, you are going to have, by 2030, about 1 billion users, digital health users in India. The used cases, the classic use cases are going to be the digitally enabled chronic and home healthcare, the broad-based EMR adoption, which means portability of records, your constant analysis being possible, AI and big data and many things will come in, preventive care enabled through IoT, and then tech-enabled capacity augmentation. It's already happening through telemedicine, but it will see a next level of evolution into EICUs, virtual hospitals. If you remember, during COVID again, in many, many tier 2, tier 3 places, tier 1 hospitals activated EICUs. The specialists could guide the doctors and nurses. It will also significantly change the education space and the health education space. Through digital, through AR, VR, MR-based trainings, digital loans funding. For example, it's not going to be impossible while a payer and provider, when you are looking at a hospital discharge and the patient is waiting for the payer to, process the claim and the provider to discharge the patient, the patient can opt to sign up for a digital loan then and there and walk out of the hospital and really de-risk both the payer and provider within a few minutes and be comfortable about it, right? The other side about it is really several organizations can use also digital health to really enhance the organizational efficiencies, very large use cases that are not consumer facing but ultimately benefits the consumer. These are predictive and prescriptive, very automated digital supply chain management. There are these sort of companies that are emerging now who are telling many hospitals that we can be a much more efficient procurer for you. We'll manage all your requirements and we'll do the automatic replenishment, right? At one point of time in US when I was with Dell, one of the most hyper efficient supply chains that was built, every time somebody placed an order on the web front, by the time the machine started moving and the factory started making a computer, it normally took a few hours, maybe even a few minutes. And all the chips, all the monitors were outside the Dell factory, and there's a conveyor belt. Every time you needed an order, the belt started moving, and the pieces came in, and you collected your upfront payment from the customer within the credit card within the first 1 or 2 days, and you had a 60 days credit. So 58 days you were a bank in such a hyper efficient supply chain model. You can also have very scalable value-based procurement solutions, which basically means with digital you'll be able to see the cost along with the outcomes, patient feedbacks, and then aggregation for standalone facilities, being able to support multiple standalone facilities, bring them to a common standard of performance or quality or accreditation. Some of the points what we have talked about. So what are the roles and obligations that the strategic imperatives? This sort of a large shift requires stewardship, requires from the major stakeholders of healthcare system, a certain concerted alignment, consensus, and push. So from an investors and startups perspective, it is almost like digital as a parameter for investment, not decision, but consideration from investment decision, and greater emphasis on health tech and insurtech startup ecosystem. It's also important to look at some very breakthrough ideas, like if NABH, NABL, if you wanted to really accelerate the adoption of this, could this be tied to the cost of capital of someone applying for a loan? If you had a better quality standard, it should be safer, right? It should be more possible for it to scale, which should de-risk the banks. Healthcare providers, definitely digital first strategy. So you cannot just have a digital as a patch on to everything else you are doing. You need to rebuild your processes systems to digital at its core, and then reorient, rechange, drive the transformation. And this is a leadership mandate. Anywhere around the world when large transformation has happened, the CXOs, the CEOs have often led that charge, along with the chief medical officers, everybody on the leadership team. Comprehensive ABDM alignment and integrated digital health offerings. And finally, for the regulators and the policymakers, the policy support for legacy players to move and nudge them towards digital health offerings. Build capacity in the short, intermediate term, and policy support extension, definitely to encourage newer startups which will catalyze this transformation and providing them air cover. In conclusion, I think I'm very, very optimistic. I think NATHEALTH, I want to say a few words about NATHEALTH. What makes NATHEALTH unique is really three things. We are only focused on health, is number one. We bring into one place the top leadership in healthcare sector. And third is we have the broad ecosystem, right from hospitals, nurses, labs, diagnostics, payers, investors, medtech, now increasingly pharma, academia, research organizations. It was the vision set up about 10 years back by our founding chairman, Dr. Pratap C. Reddy, who saw that the fragmentation of healthcare ultimately in body like NATHEALTH, which brings the key actors into one place, is able to kind of break the silos and form a critical ideas around this transformation. And NATHEALTH 10 years back stood for integration. It stands today for integration, and I'm sure it will play a very important role in this journey of convergence ahead. I request all of you who are interested in this subject to being associated, affiliated, or at least share your ideas with NATHEALTH as we work with all of you towards this journey. With that, I would like to again thank you. I'm open for any questions if anybody has any. Anybody want one question answer? Or? Okay, anybody has any questions? They allow me to take a few questions, so I'll be happy to answer if there is anything. Anybody who has any can raise hands. If not, everything was perfectly clear. All right. Thank you. Appreciate it. Have a good day, everyone. Bye-bye.
Thank you, sir, for sharing your indispensable thoughts. It will definitely help all of us. We also extend our deepest gratitude to our respected guest of honor who has graced the occasion with his presence and enlightening our audience. We request you, sir, to kindly join the audience for our next session.
As quoted by Abraham Lincoln, the best way to predict the future is to create it. Thank you, everyone, for being such a gracious and patient audience. I look forward to that you all stay for the next sessions.